So despite all the advances in imaging technology, the most important imaging modality for evaluating bone tumors is still the humble X-ray. So combined with the clinical information, a large number of these bone tumors can be identified just on the X-ray. So what kind of clinical information you should look for? It's very important to have this clinical evaluation of the patient before you study the X-ray. Most important is to know the age of the patient. That is because bone tumors have a predilection for certain age groups. Now since here we are discussing only pediatric bone tumors, multiple myeloma and bone metastasis are not in our differential diagnosis. Similarly, giant cell tumor of bone and chondrosarcoma are extremely rare in this age group, and therefore they will not be a standard consideration in the differential diagnosis of any bone tumor in this age group. Regarding symptoms, one must know what is the symptom, whether there is a pain, whether there is any swelling, or whether this was just an incidental finding on X-ray, which is very common in the pediatric age group because a lot of X-rays are done for minor injuries or maybe certain fractures. If there is a pain and swelling, you should also know what is the duration of this complaint and what is the evolution, whether it is resolving, whether it is worsening, or whether it is stable. Then you should also know what is the location of this complaint. It is very important that you correlate the location of the pain with what you see on the imaging. Sometimes you may have some incidental finding on the imaging which may be totally unrelated to the patient's complaint. And then you should also inquire for any history of injury, whether it is trivial or significant. Next we go to the X-ray. So what is an ideal radiograph for study of bone tumors? One is it should be a very good quality X-ray because there are a lot of subtle things you should look for in an X-ray whenever you are studying a bone tumor. The other thing is it should be preferably a true size X-ray. Nowadays with the digital X-rays you get these shrunken X-rays where a lot of details is lost. You should also have the X-ray in both planes, AP and lateral views, and you should have the entire bone in the X-ray, and the joint above and joint below should be visible. Now how do you read a bone tumor X-ray? X-ray reveals a lot of information about the bone tumor, but you should go about studying it in a very methodical way. So these are the points which you should look for. One is topography of the lesion, which bone it is affecting and where in that particular bone this tumor is. What is the borders of this lesion, that is where the normal and abnormal meet, also known as the zone of transition. Next you should look at the pattern of bone destruction. Look for the periosteal reaction, what kind of matrix this tumor is producing, and whether there is any soft tissue involvement or not. So we will go each one of these topics one by one. Topography of lesion. Now bone tumors have a predilection for specific bones, and even in a particular bone it has predilection for certain specific sites in these bones. So you should first find out which bone is affected, then within the bone whether it is an epiphyseal, metaphyseal or diaphyseal lesion, whether it is centric or eccentric, and whether it is cortical, medullary or a surface lesion. Which bone? Why is it important? Certain tumors arise in very specific locations of certain bones. Like periosteal osteosarcoma is very typically located in the posterior surface of the distal femur. Similarly, adamantinoma or osteofibrous dysplasia typically would be in the diaphysis of the tibia. Chondromyxoid fibroma is most commonly seen in proximal tibia. Now, within the bone you should see whether this lesion is epiphyseal, metaphyseal or diaphyseal. For example, chondroblastoma is typically an epiphyseal lesion. So if you see a lytic lesion in the epiphysis in a symptomatic child, chondroblastoma should be one of your most important differentials. Metaphysis, this is the most common site for most bone tumors. So osteosarcoma, osteochondroma, aneurysmal bone cyst, simple bone cyst, non-ossifying fibroma, all of these you will see in the metaphysis of a long bone. Diaphyseal lesions, you see adamantinoma, osteofibrous dysplasia, fibrous dysplasia, periosteal osteosarcoma, Ewing sarcoma, periosteal aneurysmal bone cyst, all of these would typically appear in the diaphysis of the long bone. Then you should see whether this lesion is centric or eccentric. How is it related to the central axis of the bone? There are certain lesions which are purely centric, that is simple bone cyst, enchondromas, sometimes fibrous dysplasia. These are centrally located. Most of the centrally located lesions are benign. On the other hand, most of the other lesions are eccentric, characteristically osteosarcoma, giant cell tumor, aneurysmal bone cyst, chondromic xeroid fibroma, non-ossifying fibroma, and so on. Then you should see whether this lesion is medullary, whether it is cortical, or whether it is a surface lesion. So all these centric tumors are certainly medullary, and most of these eccentric tumors like aneurysmal bone cyst, giant cell tumor, osteosarcoma, non-ossifying fibroma, etc. are medullary lesions. On the other hand, fibrous cortical defect, osteoid osteoma, osteofibrous dysplasia, adamantinoma, most of these are cortical lesions. Then comes the surface lesions, periosteal osteosarcoma, paraosteal osteosarcoma, juxtacortical chondroma, periosteal aneurysmal bone cyst, osteochondroma, these are all surface lesions of bone. So knowing where this lesion is in relation to the bone really helps you in narrowing down your differential diagnosis. Then comes the border of the lesion, that is zone of transition. This is very important in differentiating an aggressive or a malignant disease from a benign condition. So what is border of the lesion? It is a radiological zone where the normal and the abnormal meet. It can be either a wall or a line or a porous, free for all border. So if there is a sharp demarcation with sclerosis, we call it a wall. If it is a sharp demarcation without sclerosis but just a line which defines what is normal and the abnormal, and then there is an ill-defined region which is an interface between the lesion and host bone, you can't really differentiate where the disease ends and where the normal bone begins. So both the wall and the line are called as narrow zone of transition, whereas where it is totally ill-defined, that is called as a wide zone of transition. So for all practical purposes, this is what we should know, whether the zone of transition is wide or whether it is narrow. So all these narrow zone of transition typically indicates a benign condition. So if it is a wall where there is a sclerosis in the zone of transition, it is almost always suggestive of a benign lesion. If it is just a line, in most cases it still suggests a benign lesion. And where it is wide, it definitely represents an aggressive process, and most likely it is a malignant condition. So these are examples of a narrow zone of transition, that is a non-ossifying fibroma, and that is a simple bone cyst. This is a classic example of a wide zone of transition. This is an Ewing sarcoma of distal femur. Then we come to the pattern of bone destruction. This has been typically described in three ways. One is geographic, where there is uniform destruction with well-defined borders. The next is moth-eaten, which is patchy areas of destruction with ragged borders, and the permeative pattern of bone destruction, where there is ill-defined area of bone destruction which spreads through the bone with no defined border. For us, what we need to know is whether it is geographic or whether it is non-geographic. Geographic indicates a benign condition, whereas non-geographic indicates a very aggressive or a malignant disease. So here we have examples of the geographic pattern of bone destruction, that is simple bone cyst and non-ossifying fibroma, and on the right or left? Right side. Right side, it is a Ewing sarcoma of the distal femur. Then we look at the kind of periosteal response this tumor is evoking. This has been divided into two, whether it is solid or whether it is interrupted. So when we say solid, it is basically what we would describe as a cortical thickening. So it is a single solid layer or multiple closed, opposed and fused layers of new bone over the cortex, which indicates a long-standing or a slow-growing benign process. This is X-ray of an osteoid osteoma on the left, and on the right we are seeing the sequelae of a osteomyelitis. On the other hand, when we come to interrupted reaction, it suggests a malignant or a highly aggressive non-malignant process, and these have been variously described as sunburst pattern, lamellated pattern, velvet pattern or Codman triangle. It does not matter which pattern it is. What you need to know is that it is an interrupted periosteal reaction. So these are examples of interrupted periosteal reaction. You have this sunburst on the right, next is the onion peel appearance, and the last one is the Codman triangle. This is an X-ray of a distal femur Ewing sarcoma, where you see practically all of these findings. Then you come to the type of tumor matrix. Tumor cells form extracellular matrix which may be in the form of osteoid, chondroid, myxoid or collagen material. So this can be identified on an X-ray. So the osteoid or bone forming tumors can appear as irregular partially mineralized bone matrix within or adjacent to the area of bone destruction, or it can also look like cottony or cloud-like densities. So basically it's disorganized osseous tissue which really indicates an aggressive bone forming tumor which is osteosarcoma. So this is how it would look like on the X-ray. Then you come to the spotty calcification in the tumor matrix which indicates a chondroblastic process which is typically a punctate, curvilinear or popcorn-like calcification in the matrix, and this is a classic finding in a cartilage lesion which you may see in an enchondroma or a chondrosarcoma. Then comes the ground glass appearance which is typically seen in fibrous lesions like fibrous dysplasia, and sometimes you may see radiolucent lesions which is typically seen in hollow tumor-like lesions like simple bone cyst, interosseous ganglion. So this is the X-ray appearance of a chondroid matrix. This is a ground glass appearance in a fibrous dysplasia. Then you look at the soft tissue mass. With very few exceptions like giant cell tumor and aneurysmal bone cysts, benign bone tumors usually do not have an associated soft tissue mass. So if you see a soft tissue mass, you should be very careful. These are features of many advanced malignant and aggressive lesions. You should also remember that some non-neoplastic conditions may also have a soft tissue component, especially osteomyelitis. So these are the X-rays of distal femur osteosarcoma and a proximal femur Ewing sarcoma where you see a large soft tissue swelling. Then you go to the number of lesions. If some benign lesions tend to involve multiple sites like polyostotic fibrous dysplasia, enchondromatosis, multiple exostosis, eosinophilic granuloma. So if you see multiple lesions in a child, it is more likely to be a benign condition. On the other hand, primary malignancies are rarely present as multifocal disease. So that is multiple exostosis, multiple enchondromatosis and fibrous dysplasia of the pelvis and femur. The first X-ray is that of an Ewing sarcoma distal femur, the other one is of osteosarcoma distal femur. So to summarize benign versus malignant, benign lesions usually are well defined sclerotic borders, geographic pattern of bone destruction. If at all they show a periosteal reaction, it will be solid and uninterrupted and they will generally not have a soft tissue mass. On the other hand, malignant tumors have poorly defined borders with a wide zone of transition, moth-eaten or permeative pattern of bone destruction. They will have an interrupted periosteal reaction and they are very likely to have a soft tissue mass. Thank you.